right. Thank you, Dr. Rice, for that lovely introduction. And to all, thank you. It's been a wonderful 3.5 going on end of 4 years. Ask my interns on OB. And, it's all the hard work and dedication to resident education that's gotten me the wonderful fellowship that Dr. Rice alluded to. So today I'd like to talk to you about conservative management of endometrial cancer. An interesting topic perhaps for a budding gynecologic oncologist. But, we spent the last hour discussing complications with cases. And, just within the last year, we've had women who have had significant morbidity or even mortality associated with their cancer surgery rather than their actual cancer. And so it's with complications like that that bring this topic to my mind. And so really, with the exception of perhaps ovarian cancer, treatment of cancer has gotten progressively less radical and really more patient-oriented. I wanted to highlight a few possible directions that this is going to go in, or potentially could go for endometrial cancer. So I have no financial relationships to disclose or conflicts of interest. Just for background, we'll talk a little bit about endometrial cancer in general, and then move on to some conservative medical and then conservative surgical options. So, epidemiology. Around 3% of women in the course of their lifetime will be diagnosed with endometrial cancer. It's the number 11 cancer in the United States and the number 1 cancer of female reproductive organs. National Cancer Institute's surveillance, epidemiology, and end result program had an estimated 60,000 new cases in 2016 and 10,000 deaths related to it. And so if we look at the last 10 years, endometrial cancer, or uterine cancer rather, including endometrial cancer, has been on the rise. And that's been even more dramatic for different subpopulations. So for Black, Hispanic, Asian Pacific Islander, American Indian, and Alaskan Natives, all have seen even more dramatic increases in their rates of uterine cancer. Fortunately, however, 67% of endometrial cancer is local at the time of diagnosis, and when diagnosed at a local rate is associated with a 95% 5-year survival. So compared to many forms of cancer, endometrial cancer affects a younger patient population with a median age of diagnosis of 62. Moreover, approximately a quarter of women at the time of their diagnosis will be premenopausal. So to slightly digress, but it'll make more sense, I'm sure. One of the highest risks for type 1 endometrial cancer is exposure to estrogen, and one of those risk factors is obesity. And this graph here shows in blue the percentage of adults in the United States who are obese, and that has also been steadily on the rise. And then below, the rates of obesity in youth are also increasing. Currently, greater than a third of the United States is obese. And not only that, but obesity is dose dependent, specifically for endometrial cancer. So not only with increasing rates of obesity do we see more endometrial cancer, but it's also increasing at an increasing rate. It follows more of a cubic line graph, where these people who are super morbidly obese have that much higher of a risk of developing endometrial cancer. As I alluded to, there are 2 types of endometrial cancer. Type 1, endometrioid, which is typically estrogen related, and any other medical issues that may end up increasing estrogen exposure are risk factors. And then type 2, or non-endometrioid, which includes serous, clear cell, and mucinous cancer, for example. I bring this up purely to allude to the fact that we're really going to be talking about type 1 endometrial cancer primarily today. So clinical pathology, even though my talk's entitled Conservative Management of Endometrial Cancer, we really can't talk about that without talking about the precursor disease, so endometrial hyperplasia. It exists as a spectrum of disease, and the WHO 94 criteria, skipping ahead. WHO 94 classification has 4 different types of a spectrum of endometrial hyperplasia. Simple hyperplasia, complex hyperplasia, simple atypical hyperplasia, and then complex atypical hyperplasia. Now, because endometrial cancer typically occurs in a bed of otherwise benign hyperplasia, it's associated with, when people have an endometrial biopsy that shows that pathology, it's associated with a concurrent risk of endometrial cancer at different levels. So here, in simple hyperplasia, it's associated with a 1% chance of concurrent endometrial hyperplasia or endometrial cancer, all the way up to complex atypical hyperplasia, which has a risk of 29 to 48%. And the GOG 167 study found that women with an endometrial biopsy diagnosis of complex atypical hyperplasia have a 42.6% chance of having endometrial cancer at the time of that biopsy, or at the time of their hysterectomy for that biopsy. So more recently, the International Endometrial Collaboration Group came out with their own recommendations for classification. Now, this was primarily to address the fact that even though we have that, the WHO 94 guidelines, with that much of a variance in the possible concurrent cancer, it's not really an effective clinical decision-making tool because of those differences. And so they recommended changing the pathologic diagnosis based on glandular volume, architectural complexity, and cytologic abnormality, where they actually get a grading score, and that grading helps them go into one of 3 different categories: benign endometrial hyperplasia, endometrial intraepithelial neoplasia, and then endometrial adenocarcinoma. Now, similarly, because of endometrial biopsy is not a complete sampling, there's also a concurrent risk of endometrial cancer at the time of those diagnoses as well. But this is much lower with endometrial intraepithelial neoplasia than the complex atypical hyperplasia, with a concurrent risk of about 19%. So ACOG in 2015, in their committee opinion, recommends using this because for a general clinician, it is a little bit easier to make that decision in regards to therapy based on this tissue diagnosis. So, up here we have the FIGO endometrial cancer grading system. This is based off of the nuclear atypia when you look under pathology. And then also the surgical staging system. I merely have this up here to talk about or mention the fact that we're going to be referring primarily today to grade 1 or grade 2 endometrial cancer, and then stage 1A, where there's less than 50% of myometrial invasion. So, standard treatment for endometrial intraepithelial neoplasia or complex atypical hyperplasia is kind of either surgical or medical. Surgical management is typically hysterectomy, and options are vaginal hysterectomy, laparoscopic, or abdominal approaches, although many argue that given the concern for a concurrent diagnosis of cancer, being able to evaluate the adnex at the time of surgery makes abdominal or laparoscopic more beneficial. And then definitely that supracervical hysterectomy and morcellation and ablation are all unacceptable because you could potentially either mask symptoms of endometrial cancer going forward, seed an unknown cancer diagnosis, or simply miss some sort of cervical extension. Surgery certainly gives a definitive diagnosis and can treat pre-malignant disease. And then as far as medical management, which I'll talk a little bit more about in just a moment, there's really no well-standardized therapy. Now, Chandra et al. In the Journal of Gynecologic Oncology recently in 2016 came out with a publication that involves this large flow sheet, which probably makes some of us think a little bit about the ASCCP guidelines for management of cervical cancer. or pap smears. So for here, they recommend for simple hyperplasia, just low dose progesterone. I really wish this would work. They recommend low dose progesterone. For complex hyperplasia, however, depending on whether a patient's premenopausal or postmenopausal, you have some options. They do recommend low dose progesterone first. However, if there's no response in premenopausal women, they recommend switching to high dose, whereas in postmenopausal women, they recommend proceeding with hysterectomy. And then if there is a response, then people go into this surveillance program. For atypical hyperplasia, if women are postmenopausal, recommendations are hysterectomy. However, if they're premenopausal, you could consider high-dose progesterone therapy and then hysterectomy if they don't respond. And then treatment for early endometrial cancer is typically total hysterectomy with bilateral salpingo-oophorectomy, and then plus or minus surgical staging, which can include lymphadenectomy, all of which the decision-making process for that is kind of beyond the scope of the topic today. So really what I want to focus on today is what about those patients who don't really follow into those guidelines or who have desires outside of the recommendation for hysterectomy. Specifically, people who are desire to preserve fertility, women who are premenopausal who are concerned about the effects of lack of estrogen, women who are not good surgical candidates or can't tolerate Trendelenburg. And what are their safe options? So now we'll switch to the conservative medical management. So as I alluded to earlier, progestins is really the most well-researched treatment for hyperplasia. This is just a list of the most commonly available progestins and their dose typically used for hyperplasia. And then what OB-GYN talk isn't complete without a slide featuring the menstrual cycle. So really what I want to talk about is just a small portion of this. This is all pregnancy related, so you can block out this side of the graph. But here, if we're looking at the growth of the endometrium and then also the concurrent estrogen exposure, you can see that once progestin starts getting on board, you slow the trajectory of the endometrium, and then when progesterone goes away, it's getting sloughed off. And really the function of progesterone is to help transition to the secretory stage. And it does have anti-mitogenic effects and thus mitigates the effect of estrogen on the endometrium. So first study I wanted to talk about today is just a very clean study to kind of show what kind of effects progesterone can have in low-grade hyperplasia. This was just a prospective observational study where 80 women were randomized to either received either cyclic or continuous medroxyprogesterone acetate. They all had endometrial hyperplasia without atypia. And then they did endometrial sampling after 6 months. And now, if simple hyperplasia is left alone, even without any progesterone therapy, about 80% of women will spontaneously regress, but with the addition of medroxyprogesterone, they did have a 90% regression in the cyclic group and an 82% regression in the continuous group, which was statistically significant. However, the continuous group did also have higher rates of nausea, acne, and menstrual changes. This study is probably the best systematic review out there for use of progestins in low-grade or higher-grade endometrial hyperplasia with atypia or low-grade endometrial cancer. This was a systematic review done by Gunderson et al., published in 2012. And they looked at 111 patients with complex atypical hyperplasia and 280 patients who had grade 1 endometrial adenocarcinoma. Because this was a review of a number of different studies, these patients all received different forms of progestin progestin therapy. But they did find that 77.7% of patients demonstrated some response to hormonal therapy. And the average time of that response was 6 months, and they had a median follow-up of nearly 4 years. And so when they further broke it down, you can see here complete response in the cancer group was almost 50%. However, there was a recurrence rate of 35%. And then about a quarter of patients, regardless of treatment, did have persistent disease. There was also pregnancy data for about 315 of these patients, and they found, and this was combined assisted reproductive therapy and just spontaneous pregnancy, but found over a third of patients were able to get pregnant while, after getting treatment for their pretty substantial disease. This is probably one of the better published studies out there as far as strength of data, because it's just one of the few randomized control trials that's been done. And they were using the levonorgestrel IUD, Mirena IUD, in patients in Norway. And 170 women with endometrial hyperplasia were randomized to either get the progesterone IUD or oral continuous medroxyprogesterone or oral cyclic medroxyprogesterone. And they had several different types of hyperplasia included in their study. Here, SH in the bottom, simple hyperplasia. So if we look, the top line is the IUD group, and they had 6 out of 6 patients respond. Oral continuous had 6 out of 6 patients respond, and then oral cyclic had 7 of 11 patients respond. When we get to a higher grade of dysplasia, complex hyperplasia, 41 out of 41 patients again responded to the levonorgestrel IUD, and fairly high but lower response rates for oral continuous and oral cyclic. And then if we look at complex hyperplasia, again, 6 out of 6 responded with IUD, 7 of 8 with continuous oral medroxyprogesterone, and then only 3 out of 5 for the oral cyclic. These are small numbers for complex hyperplasia, certainly, but it does suggest that patients are getting a response, and maybe even that the response is a little bit better with the IUD compared with systemic progesterone. So this is another study that I wanted to highlight. This group was looking at what kind of factors made it more likely for patients to relapse when they got treatment with progesterone. So this was a retrospective cohort of 88 patients with complex atypical hyperplasia or well-differentiated endometrial cancer. Again, they were treated with a whole number of different types of progestins. They had a median follow-up of 61 months. And what was nice is that this group actually included a preoperative MRI to try to figure out whether or not these patients truly were stage 1A to see if there was myometrial invasion. And they found that 87% of their patients regressed. Regression was a little bit higher in patients with complex atypical hyperplasia compared to with patients who had endometrial cancer. And then they had relapse data for 71 of the 77 patients and found that 25 of those 71 did relapse. Ultimately, 32 underwent eventual hysterectomy with only 1 case that had any myometrial invasion. So even though these people were being managed conservatively, these are fairly good outcomes for a pretty long period of time after their initial diagnosis. They did find that BMI greater than 30 and then a diagnosis of endometrial cancer were both prognostic factors that made patients less likely to respond to progestin therapy. So another form of medical treatment is gonadotropin-releasing hormone analogs, which when given continuously can suppress the hypothalamic pituitary ovarian axis, thereby inhibiting estrogen production. And this appears to have a direct anti-proliferative effect on endometrial cells, and thus how it could be effective as a treatment for endometrial hyperplasia. And so Agorastos et al. Published a single-arm study of use of Lupron given every 28 days for 6 months, and to 42 women who all had endometrial hyperplasia. Interestingly, they had good response from patients, but did have a fairly high recurrence rate in 7 of the 42. And but all of these patients were from the simple hyperplasia group, not from the complex hyperplasia group. So this study, really there's not a whole lot of other great data for GnRH agonists, so there really needs to be more studies in order to use this in a clinical setting. Another interesting medical treatment available is metformin, very common. Biguanide, I can't pronounce that. It's often used to treat patients who have insulin resistance, and insulin resistance has been shown to be associated with an endometrial intraepithelial neoplasia. So there is an ex vivo study that was published by a group in the Journal of Steroid and Biochemical and Molecular Biology that showed that progesterone receptors were upregulated in endometrial cancer cells when given metformin, kind of suggesting how it could potentially make it an effective treatment. And so it's now being studied in a number of clinical trials, both by itself, but also with different progestins, either oral or IUD forms. And there was a small pilot study published in the Journal of Gynecology in 2014 that showed 75% response in a group that got metformin in addition to progestin that was much higher than the response rate for just the progestin alone. So to kind of summarize medical management, with progestin therapy certainly has been shown to be effective, but perhaps not as to the same degree as surgical management. Risks of conservative management seem to increase with worsening degrees of dysplasia. Progestins are the most well studied, and then there may even be a benefit for local progestin versus systemic progestin use, but again, kind of that data doesn't exist. The most recent Cochrane review in 2013 suggested that more data needs to be gathered before levonorgestrel IUD should be the first-line treatment for hyperplasia. So transitioning to surgical options now. I'm going to start out with a little bit of background here, but this is data from the newest update from the Nurses Health Study, which was published in 2013. And we now have prospective cohort data for greater than 30,000 women over the last 28 years who've underwent a hysterectomy for benign disease that's shown that women who have a hysterectomy and their ovaries removed at the same time have a higher rate of all-cause mortality than women who underwent a hysterectomy with their ovaries conserved or remained. And that difference is 16% versus 13%. Furthermore, if you break it down, oophorectomy was associated in these patients with a higher risk of cardiovascular heart disease, lung cancer, colorectal cancer, total cancers, and again, all-cause mortality. And that even increased further when you looked at a subpopulation of women who were premenopausal or under the age of 50 at the time of diagnosis, where all-cause mortality was even higher, a higher risk factor. However, this difference did go away when patients either had a history of being treated with estrogens or estrogen therapy or were currently on estrogen therapy. Again, just highlighting the importance of estrogen in benefits to all-cause mortality. So, as I mentioned earlier, low-grade endometrial cancer, when diagnosed as local at the time of diagnosis, has a 95% 5-year survival rate. And so Ward et al. In 2012 published a retrospective cohort analysis using the SEER database of patients diagnosed with endometrial cancer, and found that cardiovascular disease was the leading cause of death among patients with endometrial cancer, with 35.8% compared to disease-specific death of 18.9%. You can see the top line with cardiovascular disease, 35%, endometrial cancer, 18%. And this was even higher when you looked at women under the age of 60, again suggesting the benefits of estrogen. And the risk of death related to cardiovascular disease versus endometrial cancer seems to cross each other around 14 years. Likely because of this fact, Wright et al. Looked at a retrospective cohort of 15,000 women under the age of 50 in the National Cancer Database, and found that women treated for stage 1 endometrial cancer with ovarian conservation were not adversely affected in their overall survival. So these women who had their ovaries remained in, no difference in all-cause mortality related to those who had. And so further, the same group then looked at the SEER database and had 86,000 women who were surgically treated with stage 1, type 1, grade either 1 or 2 endometrial cancer. And specifically looking at women under the age of 50, or looked at all women, and found that reasons for women to have their ovaries conserved included those under the age of 50, those with grade 1 endometrial histology and tumors less than 2 centimeters. These were all independent factors for ovarian conservation. And again, confirmed that cause-specific, i.e. related to endometrial cancer, was not changed by the fact that their ovaries were left in. And that overall survival was actually higher in women who had ovarian conservation. And so if we look here at their Kaplan-Meier curves, I apologize for both not really being able to point and then the size of the font, but this is just cause-specific survival curves for grade 1 endometrial cancer. And then if we look over at overall survival with all-cause mortality, you can see in the red is ovarian conservation, and there's a higher survival curve for these patients who had their ovaries conserved, even though they had grade 1 endometrial cancer. However, this difference went away if you go to a higher level of histology in grade 2 cancer, which is the bottom of the graph. Both of, this kind of suggests, when we're removing these patients' ovaries at the time of their low-grade cancer diagnosis, are we really doing them any favors? It's interesting data. So moving on to another surgical option, vaginal hysterectomy. Now, in 2009, we're all familiar that ACOG came out with their committee opinion stating that for benign disease, vaginal hysterectomy should be the preferred approach when it is feasible, due to the benefits for operation time, decreased complication rates, and increased cost effectiveness. And then just to note, if we're talking about ovarian conservation, that the rates of success with leaving ovaries or being able to remove ovaries at the time of vaginal hysterectomy has a lot of variance, but has been published between 65 and 97%. And so what data exists for treatment with vaginal hysterectomy with patients who have endometrial cancer? There's not a whole lot. This is a retrospective study at the University of South Florida where they looked back at the women that had been treated in their facility with a vaginal hysterectomy for endometrial cancer. And the reason that these women got a vaginal hysterectomy is because they were not good surgical candidates at the time. Primarily, these patients had endometrioid cancer. 73% were obese. 81% of these patients had 2 and 56% had three significant surgical risk factors. And they found that this was a feasible way to treat these patients. Two ended up being converted to laparotomy, and there was one need for reoperation. And there was not great follow-up with the study, but of the 46% that had follow-up for 3 years, there were no reported recurrences. Other available studies for vaginal hysterectomy in endometrial cancer. This is a retrospective cohort that was published by Beretta et al. They looked at 154 patients with early stage endometrial cancer. 113 underwent vaginal hysterectomy and 41 underwent laparotomy. Interestingly, the vaginal hysterectomies were all done under spinal anesthesia. And the reason, again, that these patients got the surgery was that they were not great surgical candidates. They all had statistically higher medical compromise or surgical risk factors, including obesity, hypertension, diabetes, history of venous thromboembolism or cardiovascular disease. And they found that their operative time for these patients who got a vaginal hysterectomy was significantly shorter. And they had follow-up for 60 months and found that, at least for vaginal hysterectomy, and found that there was no statistically significant difference in terms of disease-free survival or overall survival for these patients. And then really the other good data available for vaginal hysterectomy and endometrial cancer came out of the state of Washington. Interestingly, one of the largest insurers in Washington, after that ACOG bulletin came out, decided that you needed to submit a formal exemption if you wanted to do a hysterectomy for any other, or laparoscopic way, or wanted to do a hysterectomy that wasn't vaginal, essentially. And so because of that, they wanted to review what how these patients were doing when they got vaginal hysterectomy compared to others. And looking at patients who had cancer, they had 346 women who underwent a vaginal hysterectomy. And then you can see the breakdown there for other types, laparoscopic and abdominal hysterectomy, and found that both vaginal and laparoscopic, even when done for cancer, again, had decreased readmissions, had fewer major complications, had fewer minor complications, and hospital stay compared with abdominal hysterectomy, which is not really surprising, but nobody had really shown before. And there was no difference between vaginal hysterectomy or laparoscopic hysterectomy in terms of complications. So to summarize options for surgical management, ovarian sparing surgery may be beneficial for premenopausal women with low-grade endometrial cancer. In addition, vaginal hysterectomy may be an acceptable alternative to patients who may not tolerate laparoscopic or abdominal surgery due to their medical comorbidities. And if we're not taking ovaries, there may even be a larger role for vaginal hysterectomy in these patients. Something which, when I evaluated this data, made me kind of consider how our culture and perhaps myself fundamentally perceive cancer. Cancer in some cases is simply another manageable form of chronic disease. When a patient's given a cancer diagnosis, they're much more likely to be devastated than when they're told that they have uncontrolled hypertension. However, in the case of low-grade endometrial cancer, that hypertension may be more substantially impacted or impact their overall survival. And so this just kind of further emphasizes that although there are recommendations for specific disease states, our treatment ultimately has to be tailored to the patient, their wishes, and their overall well-being. And with that, I'd like to thank you, and I'm happy to answer any questions.